this point is that if chronic pain is a dysfunction of your brain reading the signal from your environment where it has learned that something is dangerous, but it's no longer dangerous. So what you're proposing, indeed, is retrain your brain to read your environment correctly instead of mixing up with the chemical. Am I right?
Mick?
Mick, did you hear?
Yeah, I'm not so much on the retrain the brain thing, because if you're the desired outcome, you need to forget about curing chronic pain, desired outcome. We're nowhere near approaching. And I think that the things that we need to concentrate is allowing we as full participants in their lives to the fact that they have pain. And until we have a breakthrough to be miraculous, chronic pain the way that we're going to need to proceed. And so the approach that we've taken is, so for example, in our work, we're through some kind of, is the objective of treatment. Most of our treatment techniques are actually more behavioral, they are cognitive. In the same way that if you're training someone to be a runner, tennis player, you need them running, playing tennis, not a whole mindfulness that you need to make that happen. And so, some of our misplaced when we're going down the mindfulness road. I think the effect size there so that it's the important.
Mick, we're not hearing you super well. Are you on a speakerphone?
I am on it.
Yeah, maybe if you could pick up the receiver, that would be best. Technologically speaking.
Is this better?
Yes, thank you.
All right.
So, did you guys hear enough of that too?
No.
Okay.
In a nutshell.
In a nutshell, could you just say one sentence summarizing? Thanks.
So you can change what human beings do either by getting them to think differently or by getting them to behave differently. And so our approaches in the management of pain-related disability have been much more behavioral than they have been cognitive. And I think that the potential impact of interventions is going to be greater if we stick more to behavioral interventions than to cognitive interventions.
Pat? Yeah.
I tend to agree with Mick, but I would put it a different way. I would suggest that my behavior is controlled by my brain just as much as my cognitions. And the thing is that it's much easier to observe behavior. It's much easier to reinforce behavior. It's much easier to build around the person some supports to move into changing in behavior. The best way to change attitudes is to change behavior. We now in Canada view that seatbelts are a great idea, mostly because we've had to wear them. And because we've had to wear them, we then understand that they're very effective. People have moved towards smoking reduction, at least in major part because the places where you can do smoking are strongly limited. So it's the behavior change that at least is easier to observe, it's easier to manage, and it's easier to move forward. I'm not opposed to cognitive interventions, but I think the danger is that cognitive interventions and things like relaxation or deep breathing or whatever you want to use, if as long as it doesn't used as an excuse to avoid the behavior, if it is that I am going to go back to work when I am comfortable, then it will never happen. Or if I'm going to go back to school, in the case of a kid, when I am comfortable, then that won't happen.
Hi, it's Heather Keller, University of Waterloo. So we really like the idea of a non-pharmacological approach, but we also wanted to think about more lifestyle rather than just CBT and psychological approaches like sleep, like exercise, like nutrition. There really needs to be a holistic approach to this. And so having clinics that are involved in chronic pain needs to be an interprofessional focus. And one of my colleagues here is a PT and had another comment as well.
Well, I'll just continue to reiterate. I think that a lot of work has been done in terms of exercise and exercise approaches to rehab, or to let's say, re-education, both, and it includes both, behavioral and cognitive, and I don't think you can separate these one from each other. And I'd also just make a little plug about tele-rehab, which is more and more being picked up around the world and implemented for reaching communities and people who don't have access. So access is a big problem, and telehealth is trying to address that problem. And I think we have made great strides in that area.
That's great. So did you have a question, or are you just adding to the discussion?
I think we're adding to,
Awesome.
we were concerned that it wasn't already mentioned, that rehab and exercise wasn't
Great.
focused on.
Thanks so much. That's great. Back there. Oh, actually, Norm first, and then back there.
Back.
Yeah.
Good. Well,
Please
if I
go
have the
ahead,
microphone,
yeah.
I guess I win then, don't I? Norm Buckley at McMaster University. So around the table here, we had some comments, which were a little disparate sometimes, but the implication here is that we've abandoned a treatment of pain and we're now focused on functional recovery, which is not, although it may come as a corollary sometimes to the application of CBT. But so the other part of that is that, and this has been highlighted to some extent, but I guess, we have this knowledge translation problem. This stuff exists, it's not widely applied. So how do we ensure that the application of these modal therapies, whether they're pharmacological modes, interventional modes, physical rehab modes, or cognitive rehab modes, how do we ensure that they become part of an overarching strategy that actually allows them all to be effective?
That's great. Yeah.
So let me take the first one first, that abandonment of the idea of reducing pain. If you want, you have to look at what the technology is at this present time. And at the present time, the technology is that the best interventions seem to be not trying to reduce the amount of pain, but rather reduce the impact of pain. The effects may be somewhat different, though. So, for example, in some studies, when you reduce the impact of pain, you change the amount of pain, especially, but that trails afterwards. That trails, so that you may get an increase in function, and then later you will get a change in the amount of pain. So it's not an abandonment of that goal, but if you're trying to do something that doesn't work, it's not a very good thing to continue to do it. The other issue is people call it a knowledge translation problem. I don't think it's knowledge translation. People know what to do. People can read the literature and see what works. The problem is that there are specific incentives not to have it work. So that, for example, and barriers, incentives not to have something work, and barriers to have it work. Most even psychologists are not trained to do systematic approaches and really always do the systematic approach, and they're not held accountable for that. So there's no accountability. The outcomes are rare. Rarely do we collect outcomes in our settings, and rarely do we reflect on outcomes and use those to plan our treatments. So those aren't problems of knowledge translation. Those are problems of our structure and the way we put things together. Very often people will say, yeah, but my clinical judgment. Well, I'm sorry, if that doesn't accord with the best evidence, their clinical judgment is not valid. And that is used, and the clinical autonomy is often used as an excuse for not doing the best treatments. And to be frank, some of these treatments are harder to do than the ones that are done. So getting people to return to school or return to work is very hard work. And consequently, health professionals are no different than anybody else, and it's hard for the patient too. They'd say, well, I thought you'd get rid of my pain before I had to go back to work. And so that those types of things are hard to do, and it's easy to find ways around doing them. Maybe I should let Mick take on that one before I alienate everybody in the room.
I'll basically echo the same sentiment there. This is not a knowledge translation problem. It's really the challenge of changing clinician behavior. And I remember one of my mentors telling me when I set out on the quest to change clinician behavior, he said, really, Mick, clinical practice changes when old clinicians die. and essentially what happens is that clinicians just keep doing what they're doing. And as Pat said, there really aren't a whole lot of incentives to change, and sometimes there's actually disincentives to making changes. So in the private sector, unless the change is associated with increased revenue streams, change is not going to occur. And in the public sector, it's not so much a revenue stream as it is a workload issue, where in a workshop once, an occupational health nurse said to me, why would I want to do a better job? If I do a better job, I get more patients. So we have to look at it's like just putting the information out there is not going to be sufficient to make meaningful changes to clinician practice.
Okay, that's great. I think we have another question at the back.
This is really a couple of comments from our table. I'm Jane Green from Memorial University, Newfoundland. One of the things is that it depends where the pain is and the type of pain. If you have back pain, and admittedly, it seems to be the most common, and some things are easier to think of in terms of treating and managing back pain. But if your pain is headaches, and it's quite a different approach, and so it's just looking at those different types of pain. The second thing is, if it's a question of going back to work part-time, is that more disruptive to other people, or is that helping you? And how about the situation of workplace modifications, use of occupational therapists and so on, to having sit, stand desks and so on, so that somebody can actually do something, do their work without pain, where the ordinary desk might not be helpful. So those are just comments.
So perhaps, Mick, you can comment on that?
Oh yes, and as I mentioned, I think to make meaningful change in this area, that you're going to need to have involvement of stakeholders at many different levels. So it's not just the practitioners doing something differently, it's that we do also need to have insurance policies that make it easier for people to take a chance on going back to work, and also employers that are willing to make accommodations for individuals that have limitations.
The other thing I think is important is that if there are specific things, for instance, a stand-up desk, then, I mean, in my own office, one of my employees said, well, I'd like a stand-up desk because I find it painful. Of course you can have a stand-up desk. We'll get one tomorrow. We'll move it, we'll do whatever we can, because, but that's not the issue. That issue will help, and that sort of attitude, that culture, that what we do with chronic pain is we make accommodations, not to reduce the efficiency or effectiveness of the individual, but to allow them to continue to participate. And if participation in school is better done with instead of bright glaring lights, with migraine and shields on the windows so that you don't have to sit in the brilliant sun because that causes migraine, then there's nothing inherently wrong with that, and it's a good idea. We would want all people to have those accommodations well before they develop, chronic pain. And that again is the culture of that. What our job is to ensure that people can participate meaningfully in their society, either by going to school for kids or by going to or by working for adults. I don't think in any way are we suggesting that that's not the case.
Okay, question at the back. Thank you.
We're a little bit radical back here. But first I wanted to make the comment that I do think that our medical students are being exposed to these alternative therapies. They're aware of them, but they're not necessarily trained in them. So the first question was whether or not you should have proper certification if you're giving cognitive therapy, and whether or not once you're certified, you can properly charge for it. So with that in mind, and hoping that there is a certification that as a clinician you can be assured that you're referring this person to do the cognitive therapy, they will do it appropriately. Maybe there should be somehow a limit to how many opioid prescriptions you can get without a break in cognitive therapy. Is there a way to introduce some legislature that 4 days, 4 weeks of opioid, and then you must have a trial of cognitive?
Mick?
Well, I would say I wouldn't even have the opioids on the table there. I just don't see that that's a useful road to go. And, you know, I think what we need to do in this area is pretty, you know, it's like in terms of a major change in how we think of chronic pain patients is, because right now, most of what we do would not be considered evidence-based medicine because it's not working. It's compassion-based medicine. Is that we keep offering help because we feel compassionate for our client or our patient situation, but most of what we're offering is not working. And I think we need to totally shift how we think of chronic pain. And I think we should think of it in the same way that we think of someone with a spinal cord injury. After someone has a spinal cord injury, we're not going to keep spending all of our time trying to repair the individual's spinal cord. We're going to be trying to get the individual to be a full participant in his or her life, in spite of the fact he or she has a spinal cord injury. I mean, meanwhile, we're going to keep on our research to try to see what we can do in terms of spinal cord repair, but we're not going to make that the focus of our treatment with the patient.
The other point that might be of interest is that credentialing is all very well and good, but credentialing is one point in time. You check to see if somebody learned something. It has nothing, just because you've learned something at one point in time doesn't mean that you're going to do the same thing right at another point in time. So there's lots of evidence that in experimental situations that if you get drift, so that people drift from what they're trained to do and they drift onto something else. And that is because some things are easier to do, better, more rewarding to do, and that's what happens. So I'm not in favor particularly of credentialing. I'm much more in favor of outcome measurements and then analysis of outcome measurements against other people doing the same sort of thing. We've started to do this in surgery, for example, with the NSQIP, National Surgical Quality Improvement Program, in which you can risk stratify a patient, and then you can begin to see, well, why is it that everybody wants to do a good job? So why is it that my outcomes are not as good as somebody else's outcomes? Well, the first thing you do, is you say, well, my patients are different. But if you have a really good risk stratification method, then you can say, well, no, they're not different. And, let's look at what you're doing to try and figure out how you can do it better. So credentialing, we are a society that wants more and more and more and more credentials, but we use that in my view, to avoid the accountability that if somebody has the certification in some area, we assume that they are competent and doing the performance of the task competently, and I don't think there's much evidence for that. So credentialing, okay, but what we really need is outcomes evaluations and accountability for that. The other thing is that type of approach is only slowly being moving into our healthcare system. And when we do have more accountability and outcome measurements, we're going to see more clearly, well, what's working and what isn't working. And then the next thing is to start moving resources into things that work and out of places that it doesn't work. And that's a tough thing to do. There's all sorts of barriers to that in any given situation. So any change is going to have to require that type of restructuring And I think it's best to do it with data, not to do it on my fiat or anybody's fiat, but to do it with data. What are the outcomes? And including patients in defining what outcomes they consider to be important. And participating in that, that is a way of moving health professionals along.
Okay, I'm going to try to squeeze in one more thought since you've been so patient with the mic. One more quick thought, but then you only get 1 minute to respond.
Sorry, I talked too much.
That's okay. No, we've got great. So go ahead, yeah.
Judy Ellis from the University of British Columbia, and it's actually a perfect segue from your comment. Our table would like to address specifically the first question on the PowerPoint about promising pathways for solutions, and it turns on both expectations and endpoints. And what we discussed and would like to emphasize is the importance of establishing reasonable and realistic expectations for patients that may be similar to or divergent from those of the treating physicians, whether it's pharmacologic therapy or cognitive behavioral therapy. And similarly, helping patients to ensure that they have meaningful endpoints in mind. And again, those might be convergent or divergent from the treating physician, and very much might turn on individuals, individual populations, and cultures, and so forth. So expectations and endpoints.
And involvement of patients in defining them. So I think that is actually a great segue into our final presentation, but I'm going to let you guys finish up with one final thought first. Are you good? Yeah.
Just the way I see it, I mean, there are a lot of barriers to implementation of any other solution than chemical and medication. So what are the three main barriers to implementing those alternative ways of dealing with chronic pain?
Well, I think one of it is structural in terms of the way our institutions actually, we hire people now and we expect that they're going to continue to do that for 20 or 30 years, and the lack of accountability, I think, is the key one. If there's accountability and people are held accountable, they will change because people want, but we don't have the data now to know whether or not things are working. So without the data and the accountability brought with the data, I don't think we're going to do it. I think that's the most important, having data and accountability. And that's not easy to set up, but it is possible and made easier by using electronic data collection.